imaging in children. In unexplained visual loss to come to a diagnosis, congenital corneal opacities, as we have already seen, unilateral and dense bilateral cataracts, complex strabismus, and trauma cases. Of course, ROP and other retina problems need more evaluation. So, coming to unexplained visual loss, a 4-year-old child presented with intermittent squinting. On examination, he had intermittent exotropy of variable angle up to 30 prisms, and his visual acuity was 624 and 618 with a correction of astigmatism of only -1 at 180. And he was being followed up with over-minus correction for his intermittent exotropia. And he was a smart boy. His visual acuity was quite reliable, and the visual acuity did not improve. And the fundus showed subtle changes at the fovea. So we did an OCT, spectral domain OCT, which revealed the pathology. We could see the schisis cavities at the macula. X-linked retinoschisis was diagnosed. So previously in the 60s and 70s, histopathology showed the schisis with splitting at nerve fiber layer, and OCT, which is like an in vivo histopathological examination, showed splitting in inner nuclear layer, outer plexiform, and even the other layers. So it gives you an idea of the pathology, and reports nowadays show that an increase in vision and decrease in the size of these cysts after topical dorzolamide and oral acetylcholine inhibitors. So it is a useful tool to follow up in clinical trials as well. So X-linked retinoschisis, this child showed up the spoke wheel pattern later, and his brother also had the same problem. At about 3 years, he presented with intermittent exotropia. We did an OCT, and we could see the macular pathology. So foveal hypoplasia is not uncommon, and in association with aniridia, albinism, microphthalmia, and achromatopsia, you expect some amount of foveal hypoplasia, but isolated hypoplasia can occur, and they present with nystagmus and defective vision. Wardenberg described the fundus picture of foveal hypoplasia as absence or marked irregularity of foveal and perifoveal reflexes, irregular distribution of capillary ends, and absence of macular yellow. You can see this is the picture, foveal picture of hypoplasia in aniridia and albinism. So with an OCT, a grading of foveal hypoplasia based on different stages of arrest during development of fovea has been given, which shows 1 to 4 grading, where there is a shallow pit in the grade 1, and then going on to absence of widening of lengthening of the outer inner segment, outer nuclear layer widening is absent, and it just goes like other areas in the periphery of the retina from grade to 4. So it can even predict visual acuity, and here you can see there is an absence of foveal pit, absence of extrusion of plexiform layers, absence of outer segment widening, and outer nuclear layer widening, outer segment lengthening is absent, and grade 3 foveal hypoplasia. So you can grade in nystagmus. It's not so easy to get a good picture, but you can see there is foveal hypoplasia. The macular dystrophy is another condition where imaging helps you. In early disease, only pigment disturbance at the macula may be seen. The beaten metal appearance may not be there. And as OCT shows disruption of complete loss of inner and outer photoreceptor layers with accumulation of lipofuscin accumulation, which can be seen. And another modality is fundus autofluorescence, which is a non-invasive retinal imaging modality which provides a density map of lipofuscin and gives an evaluation of RPE. Hyperautofluorescence is a sign of increased lipofuscin accumulation, which may indicate degeneration and atrophic changes during the later period when RPE atrophy occurs. So in Stargardt's disease, there is FFA used to show up the hyperfluorescent flex and against a dark choroid, but it is an invasive tool, so the fundus Autofluorescence shows the flex better even before clinical recognition of this flex, and hypofluorescence in areas of atrophy. So, again, in a child with deteriorating vision or not improving to our expectations with correction, 11-year-old child wearing glasses for the past 4 years, not improving with glasses, with a large astigmatism of -4 at 20 and -3 at 140 degree. Visual acuity was not improving, can be put aside as an amblyopia, but corneal topography showed that inferior steepening was there, and this progressed to a steepened inferior inferotemporal quadrant, which indicated C3R treatment quite early in the disease before it becomes thinner. So an 8-year-old child was brought with complaints of poor performance at school and frequent falling, and he had some perinatal problems. Not so well delayed milestones, but somewhat backward in school. Refraction was normal, visual acuity was 636, 660, and fundus showed a very large cup. An MRI was ordered and showed occipital gliosis. So this is not an uncommon situation where periventricular leukomalacia due to perinatal insults like hypoxia, hypoglycemia, and ventricular hemorrhage, more common in prematures, are seen, and parietal and occipital cortical damage produces defective vision. And pseudo-glaucomatous cupping is not uncommon. I have done EUA some time back in these children to rule out glaucoma, and this MRI picture is very, very obviously, you can see the periventricular leukomalacia, and when the child grows, you can see superior Arnafil thinning in OCT, and later you may be able to record the inferior altitudinal or inferior field defects, which is the reason for the tripping down or falling down. So these are some of the reasons for the poor performance in school. So congenital corneal opacities have been already dealt with, but this is an interesting case of a child of 1 year old with bilateral corneal opacities and nystagmus. We did an EUA to rule out glaucoma, and A scan showed an absence of lenticular spike during A scan recording, and B scan confirmed the absence of lens. The axial length was 15 and 16 millimeters in spite of the staphylomatous look, and corneal diameter was 9 and 10 millimeters, though it looked large. And UBM showed anterior chamber details better. So a case of congenital primary aphakia was diagnosed, which has a very, very poor prognosis with whatever PKP keratoplasty you do. After a lot of discussions, we undertook this case for PKP after doing anterior vitrectomy, as was advised by Dr. Ken Nishal. He has done a lot of research on these cases, but the graft didn't survive. So whether it is, Dr. Kavita has already spoken about sclerocornea, Peters anomaly. There is a range of anterior segment dysgenesis with corneal opacities, iris abnormalities, aniridia, lens adhesions, and aphakia. And UBM is helpful in planning surgery and predicting the prognosis. A UBM-based classification of congenital corneal opacity is there, whether there is any endothelial abnormality. And it is said by a study in BJO by Dr. Ken Nishal that 20% of the times we diagnose these corneal opacities wrongly unless we do an imaging. So a child of 4 years presented with a progressive photophobia and watering, and cystic lesion was seen in the anterior chamber, and EUA showed a high IOP. UBM showed a echolucent iris cyst, and during the course of follow-up it enlarged, and we did a surgical removal which relieved the secondary glaucoma, and he is being followed up now. So pediatric cataract is definitely needs more imaging. When it is a dense cataract, to rule out posterior segment pathology, and unilateral cataract, PHPV is not uncommon cause of unilateral cataract with a microphthalmos and elongated zonules. You may be able to diagnose them. A vascular thick posterior plaque may be seen, and B-scan color Doppler can show pulsatile flow. If it is posterior, it is good to hand over to the retina surgeon. The posterior segment surgeon may be a better person to do it via pars plana rather than do it via limbal route. So during the follow-up, these cases of PHPV may develop glaucoma. It's not uncommon even in congenital cataract, whom we operate earlier than in the young age, between 4 to 6 weeks also. And often the microphthalmic eye of PHPV grows into ophthalmos, but before that stage, the parents are happier that the eyes have become more or less the same size. So we should not miss this, and a serial measurement of axial length is very important. Posterior polar cataract again shows up the posterior capsular dehiscence, which can be seen by an anterior segment OCT to predict the risk for PCR. And there is a grading of posterior polar cataract as well by ASOCT. And similarly, posterior lenticonus, even without cataract, sometimes we may have to undertake surgery for preventing amblyopia. So trauma, sometimes posterior segment pathology has to be ruled out in cataract. Orbital trauma sometimes mimics, this child fell down on his face and had some scarring over the left side, and his chin up, right-sided face turned with a restriction of elevation in adduction. We thought it is an acquired Brown's, and we had almost missed this small white-eyed blowout fracture, which is not uncommon. You don't see any hemorrhage or contusion in the child's eyes. So this was a missed blowout fracture. I think I'll skip the strabismus part. ASOCT is good to evaluate in a resurgery where you suspect you don't know what had been done earlier. So you can do an ASOCT to know the position of the muscles. Strabismus, I think I will just skip the imaging part of strabismus. A child was brought with a lot of discharging eye, no history of trauma, fall, but we investigated looking for any foreign body in the eye by CT. No, some air bubbles were seen in the orbit, but we felt there is some foreign body, and we explored and found a large thorn, bamboo thorn, and apparently they had a bamboo fencing around the house. So the take-home message is do an OCT macular and subtle macular pathology to explain the visual loss. Corneal topography, OCT, UBM can guide us to predict the outcome of surgery. And in orbital trauma, you have to correlate clinically. Thank you.
Thank you so much, ma'am, for a comprehensive talk on role of imaging in pediatric ophthalmology. So next I invite myself. Diagnosis of ROP.